everyone. I'm Dr. Krish Ragunath from Perth, Western Australia. I'm a consultant gastroenterologist at Royal Perth Hospital and a professor of medicine at Curtin University Medical School. At the outset, I would like to thank the editors of the Endoscopy Journal in accepting our manuscript titled Stratification of Barrett Esophagus Surveillance based on p53 immunohistochemistry, a cost-effectiveness analysis by an international collaborative group. I'm going to be providing you with an author commentary of our manuscript on behalf of my co-authors, Dr. Shyam Menon, a consultant gastroenterologist at Royal Wolverhampton Hospital in the UK, and Dr. Prasad Iyer, professor of medicine and consultant gastroenterologist at Mayo Clinic, Rochester, USA, and my colleague at the Curtin University Health Economics Department, Dr. Richard Norman, who is a health economist. So to give you a background of why we did this study, we all know that Barrett's esophagus is a pre-malignant condition, and almost all societies advise regular endoscopic screening, and that is done based on whether the patient has got a long or a short segment, and that is the only stratification tool we use. Long segment Barrett's esophagus patients have every 2 to 3 years surveillance, and the shorter segment have surveillance every 3 to 5 years. Although it is an effective way of doing it, still it is not cost effective because the yield from such surveillance is very, very small, and it has never been shown to be cost effective to be doing endoscopic surveillance without any stratification. Several biomarkers have been proposed as risk stratification tool, but none of them has really come into routine clinical practice. However, one such biomarker, which is p53 gene mutation, has been shown promising results in the last few years, and a number of studies have been published in this regard. Gene mutation using next generation sequencing has really shown the progression if we stratify them based on the p53 mutation. But more recently, the immunohistochemistry with p53 has also been validated in a retrospective cohort and then prospectively validated. So based on this, we embarked on this study where we realized that doing a cost effectiveness study would be beneficial for healthcare providers to justify rolling out such a program. We constructed patient-level discrete time cycle Markov modeling. And this is based on a 50-year-old Caucasian male being diagnosed with Barrett's esophagus, and the time horizon was 40 years. So the 3 scenarios we simulated was the usual standard practice of surveillance, which is 3 yearly for a long segment and 5 yearly for a short segment. And the p53 based stratification, where we used a yearly surveillance if the p53 was positive, and if it was negative, then 3 years and 5 year surveillance. And we also had a natural history model. So when we did this modeling and looked into the cost effectiveness, it showed that using the p53 stratification had an incremental cost effectiveness ratio of quite high, and was saving nearly $3,000 US. Not only that, it showed nearly 15% reduction in endoscopies being performed, and a 60% increase, close to 60% increase in the dysplasia detection. So this is a win-win situation when we are able to focus on patients who really need intense surveillance, because if you detect dysplasia, as we all know, almost all of them will be treatable by endoscopic means, either by dissection or by ablation techniques. On the other hand, it will also save patients who are not high risk from having frequent endoscopies, and overall be more effective surveillance, and also cost effective to this healthcare service. I would encourage you to read this manuscript, and hopefully there will be lot of information from the results and in the discussions that will be useful for you, and to also consider this in clinical practice. Should there be any questions, please feel free to reach us out from the email communication from the corresponding author. Thank you very much for listening to the author commentary. Thank you.